regardless of where we practice feline and canine medicine, whether you're in primary care, work in an overnight work, a weekend emergency practice, or an ivory tower. We're all going to be dealing with acute abdomen. So it's a apropos topic for this Vet Med Live series, where we're really trying to focus on some of the most common issues that we all will be faced with in the realm of emergency and critical care. You know, it seems basic to say, well, what is an acute abdomen? But it's honestly a very honest place to start. And what we want to simply define it is there's abdominal pain. It's a big fancy way of saying my patient's abdomen hurts. Doesn't tell us where it hurts, just says we've got a problem in the belly and we've got to figure it out. Now, that pain could be very minor, or it could be debilitating, and they come in absolutely moribund, near death. The pain could also be localized or completely affecting the entire cavity, to be honest. And you know, that's the challenge. Now you see this dog in picture to your right. He's not play bowing. He's certainly not trying to play in his kennel. This is what we all call the prayer position. This is his way or her way of saying, I'm not comfortable, and this is the only posture that keeps me a little bit comfortable. I consider it the abdominal orthopnea. I don't know if that's actually a term, but you know how orthopnea, when we talked in our first lecture, you know, it's assuming a position so that their breathing is as comfortable as possible. A prayer position is similar for abdominal pain. This is the only position in which they're comfortable. The clinical signs when patients are presented with acute abdomen are typically referable to the gastrointestinal tract. Doesn't tell you what the problem is, but it usually manifests as vomiting, diarrhea, some type of appetite change, usually a loss, if not complete. And don't forget the ever important component of thylism or hypersalivation or drooling. That's them saying, I'm nauseated. It's usually not orodental pain, although that's a meaningful differential. Whenever I see thylism or hypersalivation, I really worry that my patient is nauseated and I've got to figure out why. And of course, again, it could be a very mild issue, but these patients, as I'm sure we all know, could present to us with profound clinical signs. They're in shock, whether that be early compensatory shock or late decompensatory shock. You just don't know what you're going to get.